today, and most importantly, I am here to share some much needed information on how we can continue the work that we've all started as educators and focus on making our learners more structurally competent to help give better patient care and close disparities. So with that said, I am proud to present the workshop for you today entitled Demystifying Structural Competency, Promoting Anti-Racist Training in Ambulatory Medical Education. So by the end of this session, we aim to have you accomplish the following. First and foremost is to explain structural competency and its principles. It's important for this to be instilled so that you can continue to share this information at your home program and institutions, to be confident in how to structure a structural differential for case-based presentations, to practice incorporating structural and social determinants of health into precepting encounters, and to identify resources for contextualizing clinical problems within a broader structural and historical narrative. So I hope many of you by now are asking yourselves, well, what exactly is structural competency? We get that question all the time, and I am so excited to share it with you today. So in its essence, at its fundamental, structural competency is the ability of a healthcare provider and trainee to appreciate how symptoms, clinical problems, diseases, attitudes towards patients, populations, and health systems are influenced, now this is the key word, catch this, upstream social determinants of health. So in other words, structural competency is the ability for the healthcare professional to understand that a patient's access to quality housing, quality education, healthy food, jobs, transportation, influence the clinical manifestation of disease within a person and affects the types of relationships that the patient has, the provider has with the health system that they both reside within.
So to help us define some key terms that we'll be using, structural determinants of health are the social and political mechanisms that generate, configure, and maintain social hierarchies. These include racism, our labor markets, and political institutions. These in turn affect the conditions in which people are born, grow, work, live, and age, also known as the social determinants of health, examples of which include economic stability, neighborhood, education, food, and our healthcare system. And the social determinants of health contribute to health outcomes and to the health disparities that we see across social hierarchies, including across races and ethnicities.
So first, we're going to start on the ground floor, and that's making sure that you fundamentally internalize and understand the 5 critical pillars of structural competency. So number 1, identifying structures that influence clinical encounters. When a patient sees your learners or sees you for that matter, there are multiple structures that have already been at play and affect that clinical encounter, and you must be aware of this. So this is developing a working awareness and understanding of economic, political, socio-political forces that can impact medical decision-making. Number 2, you must start developing an extra clinical language of structure. Recognize language used by anthropologists, sociologists, economists, urban planners, and how they contribute to our clinical decision making. The more you familiarize yourself with this language, the more confident you'll feel with integrating structural competency lenses into your teaching practices. Number 3, re-articulate, and this is a big one, re-articulate cultural presentations in structural terms. Avoid using culture to describe what in fact are structural barriers. We see this rampant in our literature where people associate being a minoritized or racialized person with pathology, and that is not true. Race is a socio-political concept. The genetic variances between races does not impact how disease manifests. It's the environment that a patient lives within. So we must start making that shift in our language because words have power. Number 4, observe and imagine structural interventions. Structures are subject to change and are not immutable. When you talk to your learners and to other providers for that matter, they can feel very overwhelmed by the idea or concept of being structurally competent. And that is how these structures of inequity persist. They look like they're indomitable, and that is not true. We must speak change into these structures and into the learners that we're talking to. They can change, and they have. And number 5, nurture awareness of structural humility. In other words, as learners and as providers, we are just one piece of an ecosystem of change and making sure that structural inequities are mitigated, not only in our clinical reasoning, but in our healthcare delivery. So in order for us to do this in a competent way, stay open and receive the information and knowledge from our partners, specifically in the community, who have been working on these structures and changing them for decades, if not generations. So routinely talk to your learners and tell them about how to partner with community advocates. Tell them how to partner with other nonprofits and people who are in this arena working on the same problem, and how to learn from them, and how we can utilize our gifts in this whole ecosystem to help bring better structural change to deliver better clinical care. So again, I really want to emphasize that as we grapple with how to combat structural racism within the system of medical education, it is critical to deploy frameworks and strategies that have a proven track record to improve provider performance and patient care. And structural competency is a skill set that every provider must learn. And as educators and workforce developers and all the mentorship that's on this call today, we can adopt this framework to change how we perform as teachers. So for one, providers wear many hats, and developing this unique skill of structural competency in our clinical reasoning will elevate their performance, not only in the exam room, but in other arenas where providers find themselves, such as advocacy, policy development, how to be an effective and impactful researcher, and also for our hospital administrators and our leadership so that they can develop high yield outcomes. So I know we gave you a lot of information. I know that we touched on a lot of different things. So we'd be derelict of duty if we didn't give you a quick quiz to check your understanding. So to the best of your ability, go ahead and answer this question, and we'll go over it shortly. All right. Woo, look at all this participation. Okay, I was born on the 7th. So let's see if we can at least get to 70% of participation. Oh, we're almost there at 64. Okay, 67, 70. All right. Thank you guys for participating with me today. So let's go over the question. So which of the following are principles of the structural competency? And for those of you who picked choice B, which is embracing structural humility, and choice E, identify upstream influences of health, you are spot on. If you selected another answer, that is okay. There is still more to learn, and I'm more than happy to reiterate these principles, and we have more to teach you. So let's keep on pushing. Okay. So now that we have described structural competency, we want to take some time to review a traditional precepting case. Hopefully this exercise resonates with you and your current method or approach to precepting. We want you to be sensitized to area where you can improve. And also we want to edify and strengthen the areas that you're already doing well. So we're going to give you a quick scenario and hopefully get some feedback from you guys. All right, good afternoon, Dr. Ray. Tell me about the patient you saw today.
Thanks, Dr. Sun. I saw Mr. K, who's a 53-year-old gentleman and has a past medical history of controlled diabetes type 2, chronic kidney disease stage 3, bilateral knee osteoarthritis, obesity, and asthma, who's presenting for a follow-up visit. This is the first visit in 9 months due to the COVID-19 pandemic. He had COVID-19 2 months ago, but since recovered. He reports he's been unable to take his blood pressure medications for the past month and a half. His blood pressure today is 172/85. His BMI is 37, and he's afebrile. His lung and heart exam are normal. His point of care A1C is 8.1.
Okay, so what do you think is going on with this patient?
I think this patient has a few things going on. His first problem is his high blood pressure. I would like to restart him on his blood pressure combination pill. For his diabetes, his A1C is now above goal, so I would like to start metformin and refer him to our health educator for weight loss counseling.
Okay, I like that you thought of the health educator referral. Good job. So what should you be concerned about when initiating metformin in this patient?
The risk of lactic acidosis.
Yes, given the patient's GFR, I would suggest starting metformin at 500 milligrams and titrating up to twice daily as the patient can tolerate, while increasing kidney monitoring and counseling your patient about the risk of metformin with chronic kidney disease.
Okay.
So we know that there are so many of you on this call right now, but we want you to just silently reflect on what you think well and what you thought were some missed opportunities in this encounter. I'm serious, reflect. Excellent. So as you're reflecting, and hopefully you have one or two thoughts in your mind about, well, I do that, and I think that's very effective with being, and I think that could be aligned with structural competency, and versus, I missed some opportunities, I don't do that. We're going to expand on this by going into our next slide, which is going to break down the adapted 1-minute preceptor.
Yeah, I know there's a lot of people on the call, but if folks want to put stuff in the chat, that might be a good opportunity for us as a big group to reflect, share your reflection.
Excellent, excellent, excellent. So let's go ahead to the next slide. Oh, Joel, thank you. Okay, we have something there already. Missed opportunity. He's struggling to take his blood pressure meds and he's now being put back on metformin. Oh, yes. Oh, keep them coming, keep them coming. I can see these on the screen, and I think this helps inform all of us as a community about what we do well already and where there's still areas to improve. So with that said, we're going to pivot into talking about the adapted 1-minute preceptor. So the 1-minute preceptor is a teaching model or a framework that allows the preceptor to take full advantage of the precepting encounter in order to maximize the time available for teaching. I know we have a lot of clinician educators with us today, so some of you may be familiar with this framework or philosophy of teaching, and others, this may be the first time that you're hearing about it. But what we have done is use that as a launching point to then layer in and integrate how to be structurally competent with this teaching approach. So naturally, the teaching encounter will take longer than a minute, however, still will be short, but the time is spent more efficiently and it's more effective with teaching. The benefits of using this particular approach is that you can focus on providing 5 micro skills to organize the learning experience for students in the clinical environment. But as I mentioned earlier, it is limited and that it doesn't really provide support for faculty who are aiming to consistently address the social and structural determinants of health and really highlight to their learners about the upstream structural influences that are happening within the clinical encounter. Therefore, we solve this problem for you, and we've adapted the 1 Minute Preceptor to be a model that's rooted in structural competency in order to address the current limitations that it has. And we'll start with its first organizing skill. So the first micro skill that can be focused on in the 1 Minute Preceptor is getting a commitment to a structural problem related to the case. So encourage the learner to develop their critical thinking and clinical reasoning skills. Actively engage them to commit to a structural differential for a chief complaint. We have many learners who come to us after the data gathering process, but it's clear to us that they haven't really synthesized any of the information they acquired. This is the best opportunity to push them and to put their penny down on what they think is a structural chief complaint. Some example preceptor prompts that you can use are: what structural and social contributors are affecting this patient's chief complaint? Why might this patient be disproportionately experiencing this particular health inequity? How does this change your problem list? And lastly, what is your #1 differential, and why would this patient be disproportionately affected by this diagnosis? Introduce the concepts of structural and social determinants of health to your learner and help them. Look for your answers to be rooted in structural barriers or structural concepts such as education, jobs, access to food, access to healthcare, as opposed to answers that are rooted in someone's identity such as race, ethnicity, gender, or orientation. Micro skill #2 is probe for supporting evidence and address implicit bias. We all are impacted by implicit bias, and as providers, we are all in a critical position of power to affect clinical decision-making and clinical outcomes. So we must be aware of this. So uncover the student's bias in their decision. Are they making a guess, or are they coming from a reasonable foundation of knowledge when they make certain recommendations? This is a great opportunity to discuss structural humility, and also check for potential harmful effects from implicit bias. So again, some preceptor prompts that can help you effectively execute this micro skill is: I see you chose the lower cost medication. How did you come to this decision? How do you feel about time management and workflow in clinic today? We are more likely to introduce bias into our thinking when we feel rushed. And lastly, what are the patient's perceptions on their current medical condition? Micro skill 3, reinforce what was done well. Provide positive feedback that reinforces desired behaviors, knowledge, skills, and attitudes. This plays out in real time. I just got off service. My senior resident on that team was an upstander for me. He realized that I was facing my typical barrage of microaggressions while practicing medicine on the floor. And in the midst of being called miss or being asked about administrative work for the 10th time, he blurted out, "Everyone in this group is a doctor. This is our supervisor. Dr. Scott is taking care of all of us." And I was elated. And in his feedback, I praised him tremendously. "You were an upstander. Thank you for modeling that for the learners on your team." And so it's so critical that we also recognize the attitudes as well and praise that as well and give positive feedback. So let me give you some examples of how you can do this. So for one, great work on identifying the patient's current quality of housing and exposures to environmental pollutants when developing your differential for cough. That was a comprehensive social history, and I'm glad you used the social determinants of health screening tool. Nice job on identifying transportation challenges for our patients post-op visit, because this doesn't just apply to primary care, this applies to subspecialties and surgeons too, and reaching out to their primary care provider. Micro skill 4 is to give guidance about errors and omissions. Approach the learner respectfully and make sure you give timely feedback. It's so important that when they make a mistake, we address it right then and there in a compassionate, respectful way. Ensure that you address gaps in social history, specifically failure to incorporate the social determinants of health or failure to develop a structural differential in their clinical decision-making. Without timely feedback, it's going to be very difficult for the learner to improve. So here are some ways that you can do this, and I really want you guys to zoom in on this, because what I find with working and doing faculty development, this is an area where most of us feel the weakest, and where clinical educators and some of our colleagues don't feel strong. So this can be a huge area of impact that you can provide for them. So one is, I see you mentioned medication non-adherence as a reason for your patient's uncontrolled asthma. Did you probe further? Why is it important to assess for structural factors when contributing to your patient's uncontrolled asthma? And lastly, during your presentation, the social history was limited and only reported toxic habits. How can you expand and strengthen this as a part of the presentation? And the last micro skill, number 5, is to teach core structural competency pillars. So again, you can choose to focus on recognizing upstream structures that shape clinical encounters. Again, help them develop their extra clinical language for structure, re-articulate cultural presentations in structural terms, observe and imagine cultural interventions. This is my favorite one. I'm a very creative person, so I like to inspire my learners to dream and think and envision what change looks like, not only in the clinical encounter, but even at the systems level, and demonstrate and cultivate structural humility. Modeling is so powerful. The more that we ingrain this into our clinical performance and practice, the more that they'll pick up on it. So to summarize, conclude the learning encounter with reflections and next steps. So you can encourage them on a granular level about researching interventions at the individual, clinical, community, or policy level. You can also assign reading assignments on health disparities. I am notorious for that. Ask all of my learners and structural contributors. I recently had a conversation with this brilliant sub-I who is interested in doing research regarding social determinants of health and urology. And we had an extensive conversation about how to reliably collect demo data, which is a huge obstacle. And he had no idea about where he can go to read about how to effectively do this in his research as a subspecialist. There's so many opportunities for us to make impact when we adopt this teaching framework. All right, it's quiz time again. Okay, this time I was born in the 8th month. Let's see if we can get to 80%. If you can't tell already, I'm a Leo. Right. This is good stuff. This is good stuff. All right, we're getting close. We're getting close. We'll give a few more moments. I know people step up from their computer, do some things. If you've come back and you see this question on your Zoom screen, just go ahead and take a crack at it. I'm trying to see if we can get up to 80% of participation. Oh, okay. Okay. Excellent, excellent. This is such a great group. You guys participate so much. All right. Okay. We're almost there. I saw 58%, so I'm going to take that 8 that I saw as a win. Happy that we settled at 64% participation. I'm always looking at the glass being half full. All right. So the question was, which of the following is a structurally competent micro skill? So for those of you who replied with A, get a commitment to a structural problem, and B, probe and address implicit bias in the care plan, you are spot on. If you selected C or D, that's okay. We still have more time to learn, and there's a question and answer section at the end so that we can help clarify these concepts for you going forward.
All right, everyone. So with those amazing principles that we should start to incorporate as part of our structurally competent 1-minute precepting model, we're going to take a moment to talk a little bit about the structural differential. So Dr. Scott had mentioned this in passing, that we should encourage our learners to use a structural differential. But what is a structural differential and how can we use it? So a structural differential is a model that was developed to begin to incorporate structural competency into clinical reasoning, and to take that step with your learners to embed structural and social determinants of health into the way we think about disease processes, and also the ways that we think about our assessments and our plans. So these are the 4 steps of the structural differential, and I'll go through them. The first is to create a prioritized clinical problem list. This is what we usually do in the course of our clinical practice. Here, it's important to ensure that there's congruity between patient and clinician problem lists. The second step, and this is where the structural differential differs, is to identify structural root causes for clinical problems. So this involves eliciting upstream structural and social determinants of health that contribute to clinical problems, to make sure to integrate the historical context, and to use things like a root cause analysis fishbone diagram to help your learners identify those root causes. Once you've identified the root causes, you can then work with your learner to generate a prioritized structural problem list. So this is a new problem list that incorporates the structural root causes. It also incorporates patient priorities, preferences, and concerns. It's important to prioritize urgent problems and problems for which there are clinic and community resources available. And then finally, the last step of the structural differential is to develop solutions to address those structural problems. And here it's vital to prioritize patient priorities, concerns, and experiences when developing these solutions, to imagine solutions at the individual level, health system level, and community level, to consider individual and community strengths and assets, and to partner with interdisciplinary teams to participate in community-led efforts as part of those solutions. So we're now going to take a moment and go through the structural differential with an example scenario from a patient so you can see how this works. So this is a patient who presents to clinic with uncontrolled asthma and frequent asthma attacks. A traditional problem list would probably stop there. That's your problem, uncontrolled asthma and frequent asthma attacks. But a structural differential would prompt learners to identify the structural root causes for clinical problems. So in this case, using a structural vulnerability assessment or a social needs screener or a great social history, your learner is able to discover that your patient has poor housing conditions and numerous triggers in their home, such as leaks, mold, and pests. Your patient's building has been cited in an increasing number of housing violations as the neighborhood is starting to gentrify, and the landlord is incentivized to neglect repairs. And so you can identify these factors as more root causes of your patient's uncontrolled asthma. And so a new structural problem list would actually encourage the learner to explicitly name the structural problems on their problem list. And so in addition to uncontrolled asthma with frequent asthma attacks, a second problem would be poor housing conditions stemming from landlord neglect and exacerbated by gentrification. And then you working with your learner can come up with some solutions for this structural problem. And these solutions might be at the individual level, the health system level, or the community level. And they could include things like offering resources to report housing violations, linking to a community health worker home-based asthma program, at the health system level, referring to the clinic's medical legal partnership, and at the community society level, maybe supporting tenant-led efforts to form a tenants association with the help of some housing rights advocates, or joining larger community-led policy efforts to mitigate gentrification. So that's a little bit about the structural differential. With that, we're gonna do another quiz and see where you're all at. So take a moment and fill out this quiz question. Okay, wonderful. We got to like 60% participation. So I'm gonna go ahead and end the poll and share the results. So the question was, which of the following should you do when building a structural differential? And I'm so happy to see that nobody picked the incorrect answer. So the correct answer was integrate historical context of disparities, incorporate patient priorities, preferences, and concerns, and also name structural root causes of clinical problems. All right. Okay, so we had a moment here for you all to practice using some of these skills that we shared, the structurally competent 1-minute preceptor and the structural differential. Unfortunately, we will not be able to break out into groups. However, we do want to give you the resources so that you can go out, either you all together as a group or with other faculty members or at your institution, and practice using some of these skills. So if you all want to take a moment, this is a breakout session that's designed to be a role play. So there's someone who acts as a preceptor, there's someone who acts as a learner, and the remaining members act as observers. And then you're able to practice using some of these micro skills and also the structural differential. So if you all take a moment to get those on your phone, we'll also we also have put it in the chat already as well. So if you want to copy and paste that to keep for later, you can do that. If you're looking at one version, I recommend looking at the observer version because it has all the tools and resources laid out for you. But a great activity for you all to do. And then when you have done that activity, some questions to reflect on. How was the precepting experience? How did you use the steps of the structural differential in your group? What limitations did you experience in this encounter? How might you address differently next time? So some things to go through when you do this activity. All right.
Okay, so next what we'll do is illustrate how a structurally competent version of the case that you can work on your own time can go in the breakout discussions. I want you to particularly pay attention to the top of the slide. Like I look like a YouTuber, right? Isn't that what they do? And look for the 1 minute preceptor micro skill that appears on the screen as we're utilizing it in the precepting encounter. Okay, so Dr. Ray, tell me about the patient you saw today.
Thanks, Dr. Sun. I saw Mr. K, who's a 53-year-old gentleman and has a past medical history of uncontrolled diabetes type 2, hypertension, chronic kidney disease stage 3, bilateral knee osteoarthritis, obesity, and asthma, who presents for a follow-up visit. This is his first visit in 9 months due to the COVID-19 pandemic. He had COVID-19 2 months ago, but has since recovered. He reports he's been unable to take his blood pressure medications for the past month and a half. His blood pressure today is 172/85. His BMI is 37, and he is afebrile. His lung and heart exam are normal. His point of care A1C is 8.1.
Okay, so tell me more about Mr. K's social situation. How did COVID-19 impact him? What happened that prevented him from taking his medications?
Mr. K's household contracted COVID-19, and his mother passed away from COVID-19 shortly after. He has not been able to find work since he got sick. Mr. K is grieving over the loss of his mom, who was the main source of support for him. It seems almost everyone in his building got sick from COVID-19. He expressed really wanting to take care of himself and his health now that his mom is gone. However, he's been told his insurance is not active, and now he's worried about paying for his medications.
Okay, that's helpful to know and include in your presentation. However, you did a great job with identifying the impact of COVID-19 and what it's had on Mr. K and his insurance and the insurance issues that he's facing. So tell me more about your plan and assessment.
I think this patient has a few things going on. His first problem is his high blood pressure. I would like to restart him on his blood pressure combination pill. For his diabetes, his A1C is now above goal, so I would like to start metformin and refer him to the health educator for weight loss counseling.
Great. You and Mr. K identified high blood pressure and diabetes as being a clinical condition you both would like to discuss today. What structural and social contributors are affecting Mr. K's health?
Well, his lack of insurance and not being able to find work, I guess his lack of insurance is making him unable to get his medication.
Right. Addressing his structural and social barriers will definitely allow us to better help him with his chronic conditions. Also, we should check in with Mr. K to see how he's coping with the loss of his mama and what social support he's been getting. When we're done, I'll share a really great article with you that discusses the structural root causes of health disparities witnessed in the COVID-19 pandemic.
That would be great.
So tell me more about your plan for the social contributors that you identified in the clinical encounter today.
I can ask him more about his social supports. I'm not really sure what to do to help him with his insurance situation, though.
Well, first, let's start by reaching out to our health insurance navigator to see if we can get Mr. K re-enrolled in health insurance. It's open season, it's about to be. In the meantime, because we are a federally qualified health center, and I can go into detail about what that is, Mr. K can obtain medications from our pharmacy using a sliding scale plan. Let's go and see what's on formulary so that we can help Mr. K obtain the right medications.
Looks like the individual components of the blood pressure medication are on formulary as separate medicines. Metformin is also on formulary.
Great. Let's go see your patient. So again, we hope through that demonstration, you were able to appreciate these micro skills and how they can be applied in real time in the learning encounter. So I told you we were going to run this back. So micro skill number 1 is getting a commitment to a structural problem. Micro skill number 2, probe for supporting evidence and address implicit bias. Micro skill number 3, reinforce what was done well. We want to encourage the right behaviors. Micro skill number 4, give guidance about errors and omission. And micro skill number 5, teach core structural competency pillars.
And as a review of the structural differential, there are 4 components. The first step is creating a prioritized clinical problem list. The second is identifying structural root causes for clinical problems, and you can do this using a root cause fishbone diagram. The third is to generate prioritized structural problem list that incorporates explicitly the root causes identified. And finally, to develop solutions to address structural problems that prioritize patients' priorities, concerns, and experiences, and that imagine solutions at multiple levels. And with that, we have some resources that you all are welcome to check out. These are some links to resources and databases that are available. At Albert Einstein College of Medicine, we have a great anti-racism library that I would encourage folks to check out. It has toolkits and curriculum and a lot of great information. There's also social medicine cases if you're looking for clinical cases to use in your teaching. That's at the University of Pittsburgh. There's also great work happening at the Structural Competency Working Group at Siren and at other organizations as well. We'd like to acknowledge a few individuals, and we'd also like for you all to take a moment to give us some feedback on this session. So if folks either using your phone, you can fill out this really, really quick survey, or we'll put the link in the chat for you all. And with that, it's open to questions and answers.
Thank you, Dr.